Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome to the Gastro Girl podcast. This episode is brought to you by Sanofi Regeneron. Today we are talking about EoE treatment and adherence in children, what parents need to know, or how you can help your child stay compliant to EoE treatment. We're joined with Dr. Sophia Patel, a pediatric gastroenterologist at the Cleveland Clinic. We've had her on before. She's so awesome, and we're so happy to have you back on again. Thank you for joining us, Dr. Patel.
Thank you for the invitation, Jackie. I always appreciate it and love talking about EoE, so I'm glad to be back.
And we have some exciting updates to share with parents and patients. But let's first set the stage for those who may have joined this episode listening in. What is EoE?
So EoE, or Eosinophilic Esophagitis, it's a mouthful, either way you say it, is a disease that causes inflammation in the esophagus that's usually caused by a type of an allergy process. Those allergies can come from different foods that we're eating, environmental allergies, or it can be just because patients have issues with a lot of different allergy type symptoms. And essentially what happens is the allergy cells trigger a response in the esophagus that leads it to become inflamed. And we call it a little bit, it gets stressed out. And that response causes a lot of inflammatory cells to get into that area. And then it causes difficulty in patients, especially kids, with swallowing. And what happens is they feel like food gets stuck pretty often. They often complain that especially meats and breads get stuck. Younger kids will have more abdominal pain symptoms, vomiting, weight loss. And it can be diagnosed as early as toddler age or even younger. And some of our patients present a little bit later in the 6 to 8-year-old. And then sometimes we have teenage patients, and it is a lifelong disease. So it does last into adulthood. And many patients just live with symptoms without coming in to talk about them. And, there are really great treatments available. And, that's what we're here to talk about today.
Yeah. And for those who may have children or young people that are already diagnosed with EoE, what about those who may be listening in and maybe recognize some of the signs that you just mentioned? Their child, even young child, is not thriving. They're fussy about eating. What else should parents be aware of, and how is EoE diagnosed in children?
So generally, when you're a parent and you have a child who's a picky eater, that can happen commonly. But what we see often is kids who will pocket food in their mouth. They take a very long time to chew. They spit things out. After they swallow, a lot of times they'll vomit later on, or specific certain foods can trigger their symptoms. So sometimes they feel like milk makes them feel worse specifically. And then those patients, oftentimes they're caught by their pediatrician because we're always monitoring growth and how patients are gaining weight and getting taller and longer. And if at some point that starts to falter, that is generally when they get referred to me, who I'm a pediatric gastroenterologist. And then when we see those patients, we do a very long and thorough history, which a lot of my patients are, I ask them about 1,000 questions, and, some of them say no to every question. And some of them, as the questioning progresses, they start saying, oh, well, that sounds familiar, or, oh, I didn't notice that, or I didn't think that was a problem. And then when we discover that maybe they have issues with swallowing, as well as if they have abdominal pain in the younger child, older kids typically have more issues with swallowing. Then we help them get set up with an upper endoscopy, which is a type of a camera scope where we put the patient to sleep, and we go in and we look with the camera to evaluate the tissue in the food pipe or the esophagus. And that's the only way that you can diagnose EoE at this time. There are a couple of non-invasive ways to do it. More recently, we offer that at Cleveland Clinic that includes like a nasal endoscopy where we don't have to sedate them. And then other centers are also offering what they call a string test, and they swallow the pill and they kind of leave it in there and pull it out. But it's not in all centers right now. So that's how it's diagnosed.
But that would be something that a parent could have a conversation with their doctor to see what the best option is for their child.
Exactly. And that's certainly something that, it's all about shared decision making. So figuring out what works best for the family.
I love that term, shared decision making. It's so important. That's why we do these episodes, so that patients can have this information to go and talk to their doctor with. So
exactly. Yeah. And it's very important to have a good patient relationship. And that kind of goes back to the adherence to medications is, that's how we get people to really buy into taking the medications and making sure that they're taking them to feel better. So
now, before we get into the treatment options, we get a lot of questions on our YouTube channel. We get a lot of emails, patients asking, is there a relationship between EoE and asthma or other types of allergies that, asthma, not allergy, but asthma or other allergies that patients could have?
Yeah, absolutely. So EoE is considered an atopic disease, and atopic diseases are a broad range of different diseases that are caused by different specific allergic pathways. So they include asthma, eczema, as well as food allergies, and patients who also have atopic dermatitis also can have a higher risk of developing EoE because they have other atopic diseases. So they're absolutely related without a doubt.
So there's some inflammatory things going on in the body that could be related.
Correct. Yeah. So it's a pathway called a Th2 pathway. And typical allergies are mediated by IgE mediated pathways. EoE, we know it has a lot of different pathways involved, but the Th2 pathway is the most commonly implicated. And that same pathway is what, triggers asthma and eczema and dermatitis as well.
So do you see patients that have some of these comorbidities in children still?
Yes, we do. We see oftentimes the patient usually has some other allergic disease history. And it can also include allergic rhinitis. I'm sorry, I didn't mention that earlier. Rhinitis, asthma, and many of our patients have all these in addition to having EoE, or prior to being diagnosed, they have asthma and they've, have had issues with it being treated and things like that. So.
Oh, that's very interesting. So let's talk about treatment options. And everyone is concerned about taking medications and they have questions. And especially if you're a parent of a child, what does that mean? So what does the landscape look like for treatment options for children and adolescents?
Yeah. So currently we have, I'm going to count them, 1, 2, 3, 4 approved treatment options for EoE. And when we say approved, there are, until recently, we did not have a medication that was FDA approved up until about 2 years ago when the original one was released. But what we were doing was treating EoE with medications that are off-label for EoE. So the options for treatment include an acid medication or a proton pump inhibitor, and you've probably heard of those before, like lansoprazole, Prevacid, Nexium, omeprazole, Prilosec. They're all types of proton pump inhibitors. The second type of treatment is a swallowed corticosteroid, which is similar to fluticasone and or mometasone, which are both swallowed medications that topically get swallowed and they coat the throat and decrease that inflammation. The third type of treatment is a food elimination diet, and that is typically what we end up doing is it does require a couple of scopes to figure out what foods are causing the problems. But primarily in children, we see that milk, wheat, and eggs are the top 3 triggers. We try not to have patients eliminate all of those foods because it can become very restrictive if they already have other food allergies or, just on their lifestyle in general. So what ends up happening is we remove either 1 or 2 foods and then we scope them to see if there's an improvement. And then the treatment is the removal of that food, and that generally treats their symptoms and treats the EoE in the long run. And then the fourth treatment we have is a newer biologic therapy called dupilumab. And dupilumab was recently approved for EoE in the last couple of years, and it has been approved in the past it's been around for about 10 years for asthma, atopic dermatitis, severe eczema, and nasal polyps. And that's been approved in children as young as 6 months for those diseases. And recently, we just had approval for EoE in the under 12 age group. So from ages 1 to 12, we do have an approval for the dupilumab as well now. In addition to the corticosteroids that I mentioned with the fluticasone, there's a newer medication called Eohilia that was just released. And it's essentially approved for EoE specifically, but it's a formulation that comes in like a packet that is easy to swallow and coats the throat as well. So we do have a couple of FDA-approved medications for the disease now, which is great because we didn't really have many up until a couple of years ago.
That's progress. So all these are okay for children and adolescents. And
correct. Yes,
you would have a conversation, obviously, with your doctor.
Yeah.
And what tips would you have? Well, first of all, let's talk about the importance of treatment. And I know I've heard this over and over again that EoE is a progressive disease. Could you explain what that means to a parent? Like it's a progressive disease.
So sometimes we're lucky and we diagnose EoE very early on in life. And sometimes we're not so lucky and patients have had symptoms for many years. And when they present to us, they're having symptoms of difficulty swallowing. And what essentially happens is over time, the inflammation that's in the throat starts off with just being kind of like a swelling or edema. And then that develops and progresses into different types of scar tissue, fibrosis, which leads to the esophagus becoming much more stiff. And that stiffening causes narrowing, and then the narrowing causes food to get stuck and even worsening dysphagia. And we know that that is a combination of having the disease over a long period of time and it being untreated. And sometimes there are certain patient populations that are more predisposed to just having that type of disease, even if they do get treatment. So there's a couple of schools of thought going on about that right now. But we know that over time, with it being untreated, it can progress into a worsening disease and cause more day-to-day symptomatic issues with food sticking and as well as the narrowing in the esophagus, which is what we're trying to avoid over time.
Yeah, we did a podcast webinar with you and your team last year, and you showed us a photo of an older man who had, was it like a pea stuck in his esophagus? Was so small.
Yeah, so it was very small. We've had things usually it's meat like chicken, or people are just out eating a bagel and it gets stuck. I had a patient who had a piece of broccoli. So we've seen everything. And a lot of times patients just avoid those foods and then they're like, okay, well, it won't never happen again. But then it becomes harder and harder because it's a progressive disease. Like even normal things that they would like to eat on a regular basis and aren't needing to avoid before also start becoming more difficult. So
yeah, this is a great point. And so I want to kind of slide into the importance of treatment adherence and then touch on what you said. You may be feeling better, things aren't getting stuck, but that doesn't mean you stop your treatment.
Exactly.
So
yeah,
can you talk a little bit about that for our listeners?
Yeah, EoE is one of these diseases where if you do stop treatment, unfortunately, that inflammation pathway will just automatically restart again. It's one of these things where we're not sure exactly what causes that pathway to really get triggered in the first place, but we know that if we're not treating the disease, then that pathway gets reactivated and then the inflammation comes back. So that is the most important part, is being consistent with the therapy. And most often with the medication therapy or the dietary therapy, it's on a daily basis that you have to take the medicine or avoid the foods. And in the case of the biologic therapy, it's a once weekly injection, which is what is the FDA approved dose based on age. In other populations and younger patients, it's once a month or once every other week. And so it's very important to continue that dosing. And I have a lot of parents who ask me, well, can we get off of this in a couple of years? And while I would love to say yes, we don't have enough data on the disease about what happens as you get older while you're on the biologic therapy. Does it help mold those pathways into doing something different over time? We just don't know that yet. And the safest thing to do is remain on the medication for a long period of time.
Dr. Patel, can you explain what a biologic is?
Yeah, biologic therapy is typically a medicine that affects a pathway early on, especially in EoE, in patients who have a Th2 mediated inflammation that causes the eosinophils to collect in the throat. So the biologic agents go and target the specific pathway and they stop that pathway from being triggered. And then what happens is it stops the whole cascade of inflammation even reaching the esophagus. So with dupilumab, we're lucky to have this because it not only stops the inflammation in the esophagus, if there's inflammation in other areas, especially with allergic rhinitis or asthma, it can treat those diseases as well, or at least improve their severity, in addition to helping with the EoE too.
And how does that differ from steroid therapy? Because we hear about that more? Can you
Absolutely.
hear about that?
So, steroid therapy and acid medications both have anti-inflammatory properties. So, they help with healing of the esophageal tissue. And because the steroid therapy is topical, so that means that when you swallow it, it sits in your throat, it coats there, and it's kind of like putting a cream on your hand almost. So, if you had like a rash, you put a cream on it, and then it gets better. So, that's kind of what the topical steroid therapy is. And steroids are stronger inflammation mediators. And the amount that we use is very, very small. So the type of steroid that you're swallowing is like in micro doses. So it's much smaller than doing, like a steroid for an asthma and inflammation or something similar to that. And it's not the same as a steroid that you're taking for sports enhancement or whatever you're trying to do there. So there are different activities in that they're more anti-inflammatory and they help with decreasing inflammation. The biologics actually target a specific pathway of that eosinophilic inflammation and block the pathway. So it kind of goes back in and it kind of affects more of the earlier pathway of the EoE, and similarly to how the food elimination works. So the food elimination, you take the food out, and then that pathway, which starts even before the biologic affects it, is not even triggered. So that's kind of how you can think about that. So we're kind of pulling away any of the actual the food that's actually triggering the initial response. So you have the initial response, then you have the biologics that kind of a couple steps down affect there. And then what the steroids are and the PPI are treating is the inflammation that's already kind of here in the throat. And in some cases, in deeper inflammation and fibrosis as well.
Now, do some patients do both, like a biologic and eliminate dietary foods or things that
Yes,
they're eating?
I've had a couple of patients who have needed both. When they restarted the foods that they were avoiding before while on a biologic therapy, they did need to go back and remove that food again. But I will say that typically the biologic therapies are fairly effective, and I would say the population of patients that need two therapies is low, and that's our goal at Cleveland Clinic, especially in our EoE clinic, is to limit the amount of medications that we need to give to patients, because you don't need to be on 3 medications and a dietary
Yeah,
elimination.
that's a
If
lot.
just one of those will work for you. So we just don't want to, we try not to make it too hard for people. So, but that is what we try to do. Sorry about that.
Oh, no, that's great. What everyone's probably thinking as a parent, I have to take my child to daycare or to school, or we have to travel. What are some tips
Yeah.
to staying on the treatment plan and being just in being in life, like doing life things? Like, what do you tell your
It is really
patients?
hard. With parents, I'd say, setting an alarm is, and I say this to my teenage patients too, like putting an alarm on your phone is probably the most important thing, is to remember to take the medicine. So the alarm goes off, it says, take your medicine, you go take your medicine. Other things that I find helpful are when I talk to parents is I try to find a time that is most convenient for them. Some of the medications you can't eat or drink for half an hour after you take them. So what I have them do is I make sure that they try to time it to after breakfast, so that they're not also brushing their teeth, rushing, and then they're waiting 30 minutes to eat. But it typically, on the way out, that's kind of what they're doing, is they're taking the medicine and then the kid is off on the bus or on the way to school. And then in the evenings, it's a little bit easier. But I've had parents who work in the evenings who, work third shift and they're up all night and then they're sleeping in the day. And, they have 10, 12, 8-year-olds who are responsible for their own medications. And that's really difficult. It's really not easy for them to be there to monitor them. But oftentimes they have another trusted adult that is nearby that can help. And it's always helpful to have, if you have a partner or someone else who spends time with the child, or even giving the medicine to the school, if that's the easiest thing to do. Because a lot of our patients also get breakfast at school, and then it's within that time period. But, the school nurse can also help out by, you can fill out a letter and send it to her, and then she can give it to them at school as well. But I typically tell my teenage patients that setting an alarm is very helpful. And I always tell them, what do you always grab in the morning? Always. And then they're like, usually it's their phone, right? So I tell them to put their medication on their phone or nearby their charger. And I'm like, and then you won't forget it. And then they're like, they're like, well, I always forget it in the morning. I'm like, okay, well, what are you grabbing on your way out in the morning? The car keys. So then I'm like, you have to remember to do this because it's all about responsibility, right? So we're trying to empower them to be responsible. And I always tell them, I'm like, your mom's not going to be there in college and forever. So you have to figure out when's a good time for you to do this and what's going to work for you. Otherwise, your symptoms will come back and you won't feel well. The patients who go to college, I think they're the ones that probably have a little bit more of the tougher time because no one's there reminding them to take the medicine. And then all of a sudden, like the auto refill of your prescription shows up and you're like, oh my gosh, I didn't take it for X days or whatever it is. And we also tell patients, and this is so simple, just to get like a pill box. They make a lot of fun ones, and it helps to remind you that you maybe didn't take it on that day. It's a little bit harder to do that with like a spray. But with the other medications like the acid medicine, it's definitely a little bit easier to remember to do that. So.
And what are your recommendations for, lunchtime and break time, recess, and going to birthday parties or vacation, traveling with the eating? Like what are some of the guidance that you give to
it is so difficult for patients who are going places and are traveling, and especially in different countries who don't like follow the same allergy pathways that we do. But interesting, I just went to London last week and they are so good about allergies. Every restaurant, every single one was like, do you have any allergies? And luckily my family does not. But it's important that the patients have to advocate for themselves. That's the hard part. And the parents are always the best advocates, obviously, when the kids are younger, to make sure to tell the restaurant that they can't have milk or they can't have this certain food. And it's different when you have like an anaphylaxis allergy or your lips swell, your mouth swells when you eat the food. With EoE, it's over time that inflammation develops. So you have to have exposure to that food multiple times for the symptoms to recur. So just because you ate a little bit of milk at a restaurant, you're probably not going to have symptoms then, but it's that additive effect that's going to cause more of a problem. That makes patients feel a little bit less worried about having needing an EpiPen or something like that when they eat a food that's related to their EoE. So that makes them feel a little bit better. But I always tell them that, one accident, it's very easy. It's a slippery slope to kind of go by, okay, well, I feel fine. Like, let me just eat 3 scoops of ice cream too today or whatever it is. But I always, we try to kind of keep it all or none, because as soon as we kind of start being a little bit flexible, then it kind of, people sort of lose control a little bit. And then, we kind of go off the deep end. So.
Yeah. And another challenge, we've heard from patients and parents is, how do I navigate explaining that my child has this chronic condition? Like, do you have any quick tips for patients and for, younger adolescents or adolescents that have to deal in social situations? Like, any tips for navigating that?
Honestly, the easiest way to put this, and I also see celiac disease patients. So I just tell patients who have EoE to tell whoever they're with that they have a kind of an allergy to these foods. And then when people hear the word allergy, I think it really does ring a bell that, okay, like we have to be very careful. And when you tell people that you have an allergy, I think they are much more cognizant that, okay, this person can't have this and we're going to try really hard. And thankfully, they're not going to, like I said, anaphylax to these foods most often. But addressing it more from an allergy perspective, it does give the patients a little bit more of like a upper hand on going different places and making sure that they know that you have, if you say you have an intolerance, then people think, okay, well, this is probably just something that you can't eat because it makes your stomach hurt. But if you tell someone that you have an allergy, which is not technically 100% true, but it is definitely an easier way for people to understand what you're going through, even with EoE. It does help with kind of explaining things to people. And that's what we give to patients for their schools, for colleges and things like that. Like we provide letters to their dorms for their school, their cafeterias and things like that. And the schools are very accommodating. I think they're so used to seeing patients with food allergies, and milk allergies are very common now too, that they do try to take the steps to make sure that everyone is as safe as possible. So,
well, you've given us some great information, and I really appreciate that. And I hope our patients do, and parents. In closing, I want to provide some inspiration and hope for patients and parents that may be dealing with this. Even though we said that EoE is not a cure for EoE, but it can be managed. I just want to set the tone as we close out this episode and give some hopeful words to our listeners today. Like, what would you tell them?
Absolutely. I think we're really lucky to be living in this time of EoE because, again, 20 years ago, 25 years ago, when we didn't know much about it, I think people were just living with symptoms. And I think we're very lucky to have such a broad array of different medications and biologics that are available for treatment. And especially with the advent of these biologics, I think that really opens the door to a lot more convenient treatments for patients. They are a little bit more expensive because they're injectable medicines and not as pleasant because they're injectable. And of course, parents don't love to give their kids shots. But we're very lucky to be in this era of EoE because there's a lot of newer therapies that are coming out, and we just had 2 FDA approvals, which is completely unheard of in 1 year for, what I consider to be a more rare disease. And I think we're really lucky to have those available now. And I think the compliance to therapy is the most important part of treatment. And that's why we're here for you. Your GI doctor is here. If something's not working for you, just make sure that you reach out and say, and I always tell my patients this, I'm like, we'll do a food elimination first. And I'm like, if it is not working in a week or two, I don't expect you to take everything out of your diet tomorrow. So, it's over time. We see how things go. And if this is something that fits your lifestyle, and these diets can be expensive, the medications can be expensive, we have to figure out what works for you. And I think having that open communication, and I tell them, in 2 weeks, message me and say, hey, this didn't work at all, just send the medicine. And I'm happy to do that. So I try not to put pressure on them or judge or say like, you have to do this, or this is the only option. So that's why we try to provide all the options, and we're lucky to have so many. So
yeah, and it's truly shared decision making, and that's what's so important for patients to know. Thank you so much, Dr. Patel. Your insight has been so illuminating, and I hope this benefits our listeners, and we hope that you join us on another episode. For those of you who are listening, don't forget to like, subscribe, and share this episode, and visit the Gastro Girl channel on all of your favorite podcasting platforms, as well as on YouTube. Thank you so much.
Thank you for having me.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.